and then we'll release this test in the end of chapter stuff too. I'm always torn about this, how much I should lecture on this chapter and how much I should just let you guys, you know, work on the test itself. But I want to at least kind of go over a little bit of it to see if there's any concepts that need clarifying, like just kinesiology concepts, if that makes sense. So please feel free to interrupt, all that good stuff. Let's see what we can do here. This is a two-part lecture. We're doing this chapter is so huge that I will not get through this chapter today. I will get through it on Monday, which is the other reason we normally would release the test on Monday, right? But I really do want you to have the ability to go through the test early if you want to. All that good stuff. Okay, chapter 21, kinesiology is what we're going to be talking about. And it is the study of human motion, right? It is what those muscles do. It's great if you know somebody has latissimus dorsi, but who cares? It's great if you know it's on the lateral and back side of their thoracic region. And it's great if you know that it kind of weaves into the thoracolumbar aponeuroses and, you know, the thoracic vertebrae of T6 through T12. And it's great if you know that it, you know, inserts into the inferior angle of the scapula and then wraps underneath the axillary region and inserts into the greater and lesser interturbicular groove there between the greater and lesser tubercles of the arm. Sorry, I'm slow today too. But that doesn't tell me what it does. Kinesiology is the study of what that muscle does. It's the study of motion. It's the study of how do I do these things. And what makes kinesiology fun, and important to massage therapists is it's how you guys invent your really cool moves. Kinesiology is how I know that, like, hey, the pectoralis major is going across this person's chest right here, and since it horizontally adducts the arm, when I have it abducted, it's in a stretch, and so if I'm trying to get to the pec minor and I know that's underneath it, it's making it hard for me to get to the pec minor because it's tight on top. So that if I were to move this person's arm in for them and get the pec major loose, it'll be easier for me to get in the pec minor. It also lets me know stuff like if I press down here and move the arm out, I am pinning and stretching the pec major. It lets me do those type of cool things. It also lets me analyze posture and be like, oh, this person's like this because of a reason. It also lets me look at really complicated movements because we've been talking about a single muscle working together, but it's never a single muscle working together. Even when I do this motion, right, the pec major is the driver, but there's 13 other muscles stabilizing my arm. It's never that simple. And the coracobrachialis also does this action too. And, you know, the anterior deltoid helps hold the arm up, but also helps pull it over. Like, there's lots of things going on in those type of movements. And so we try to look at them in a much more complex, holistic way. Mr. Jones, please.
I was just wondering if there's a specific movement that would isolate the pec minor.
Yes. Yes, there essentially is. So the pec minor, sir, it protracts or abducts the scapula and depresses it, right? So
Yep.
you know when you go to do dips?
Yes.
Okay. So dips essentially work the pec major, especially the lower fibers, right?
Uh-huh.
Well, if when you're in the dip, you just had your arms straight and you just did this,
Yeah.
you'd be working your pec minor.
All right. Awesome.
Yeah.
Because I never do that.
Yeah. So, but by the way, now you're working
the
the pec minor and the pec major when you do dips. They're both getting worked together. But if you wanted to isolate it,
and typically they are together. If you're
Yes.
working at one, it's going to be at least hitting the other one.
Yes.
But
let me give you
that makes perfect sense. I don't do that movement, so it will definitely help me.
let me give you another one, sir. Not for the pec minor, but for the serratus anterior, because you are you are ripped, and you. Mr. Jones has an amazing body. It's just a fact. Let's just say it. So, anyway, through hard work, by the way, sir, and probably superior genetics, both. But,
I got lucky too.
Yeah, no, but you earned it too. Like, you earned it. I don't want to take anything away from that. Anyway, your serratus anterior protracts your scapula. So if you get on a bench press, right? But
Yep.
you don't bench press, you lock out your arms and just, literally, just do that.
Yeah.
You will work your serratus anterior, and you're lean enough that you could really get those finger-like projections ripping through.
Yeah. No, that should be awesome.
Yeah,
Thank you.
whereas people won't see your pec minor, but they'll see your serratus anterior. And your serratus anterior gets worked in bench press already, but you could lock out with lighter weight and just, just move that arm. It's only about an inch, 2 inches.
I'd be willing to bet doing both of those combined would make your max lifts go up quite a bit because you just don't usually train that motion enough.
Yeah, they might. It depends on where your weak point is in the movement, right? Is it
Yeah,
from
exactly.
is it from the ground? Yeah, as you know, if it's way down by your chest, you start to do wider bench and things like that to make the lift off harder. If your lockout's harder, you start hitting triceps more, all that kind of stuff. Yeah, fun stuff. So you're gonna love you're gonna love this chapter, sir, because it is also the chapter for personal trainers. You know what I mean? It's the same stuff. It's the same stuff. If you guys are good at this chapter, you could go in and take a personal training test and bam, you'll understand every exercise in the gym known to man. But anyway, kinesiology is study of movement. So the reason we give you this chapter is it's a great overview because they're gonna look at bones, right? First, to make sure you guys remember your bones, which I know a lot of us have forgotten. And then they're going to look at your muscles that move the scapula and muscles that move the shoulder and muscles that move the elbow and all that kind of stuff. So they're going to break everything down that they're going to review everything that we've talked about. And that's what I do love about this muscle. We will not be going into the test that you have, does not go through this whole chapter because the test does not test you on things like muscles of the ankle and foot, and wrist and hand, I believe, and neck and stuff because we haven't gone over them yet. So I have really good news for you. You don't have that on this 193 question test because we save that for the end of the year when we go back to this test and take the entire test, which is more like 270 questions. Yay! That's right. Thank you, Tapscott. Yeah, but you'll have forgotten about it by then. I'll remind you in March. Okay. So I don't think we should have to go over the bones have bony landmarks, and those are very important to know because that's where muscles attach. This will be talking about all that stuff, about angles, and borders, and condyles, and epicondyles, and crests, and heads, and lines, and processes, and trochanters, and tubercles, and tuberosities, and spines, and ridges. There's also depressions and openings, right? Foramen means hole, and facets and fossas tend to be these kind of depressions that we see. We've learned about grooves and notches. We haven't really learned about sinuses yet, but these are the spaces of the bones inside your face usually. We haven't gotten to the face yet. It's one of the last things we do. But we remember the axial and appendicular skeletal system, correct? Right? The center one, and we know that most of the problems you have are where your axial skeleton meets your appendicular skeletal system. So it will go over all that stuff with you. It's going to go over all the bones with you. I'm skipping past this because I feel like taking the test alone will review this stuff with you. So we will not go. It's also going to go over, by the way, the actual names for joints. By now you are juniors in massage therapy, and you should know that the acromioclavicular joint is where my clavicle meets my acromion process, and my acromion process is part of my scapula. You should know the glenohumeral joint is the ball and socket joint that's actually in my shoulder. I hope that you know that I can only actually lift my glenohumeral joint up to here, and that it's actually an upward scapular rotation that allows me to get the rest of the way up. Those are some kind of fancier advanced stuff that you should know by now. So we'll go over all that stuff, all the bony landmarks and all that good stuff that I'm popping by right now. By the way, I'm not doing this to short you guys on lecture. I'm doing it because I think a lot of you know this and would rather get to the test. I'm assuming with this time. If I'm wrong, let me know. We could go down through every single thing. You're going to go over the 3 points of the pelvic bone, right? This is super important. This picture is super important. I think it highlights what we've been talking about, that your pelvis on both sides is made up of your ilium. They're kind of in pink, wineish color. The ischium and the pubis. And the two sides are connected at the pubis and at the sacrum that's between the ischium on both sides. And that's your acetabulum, which is where the head of your femur hooks, right? And we've now learned that on that ischium, a lot of muscles attach. A whole bunch of all your hamstrings, and a whole lot of hip adductor muscles attach to the ischium, and some of your lateral hip rotators attach to the ischium, you know, as well as the pubis and all that kind of stuff. But that is a huge, important area. That's why it's a big, strong handle back there. And we also know some of these other areas now, too. We know that this is the anterior superior iliac spine, anterior inferior iliac spine, posterior superior iliac spine, posterior inferior iliac spine. It looks different here, but that's what they are. Okay. Acetabular-femoral joint, which is your hip joint. Pelvic tilts will be discussed here. Remember, we measure them from the front, the top, because when the top goes forward, the bottom goes back. My thumbs just went back. So we talk about the top. Anterior tilt, posterior tilt. That's why in a posterior tilt, your bottom disappears. It actually goes forward. And an anterior tilt, your bottom reappears. It goes back. So they will put all the stuff we've been talking about into, you know, into terms and see if you can apply it. And I love that. The SI joint, the sacroiliac joint, where your sacrum meets your ilium, is the connection of all the bones of your upper body to your lower body. Everything that I do with my arms here, when I pick up this little thing right here, the weight of that has to go through my arm, into my thoracic area, down my spine, and the only way for it to get to my legs, and it has to get to my legs, everything you pick up has to be connected to the ground, it goes through my sacrum. And where my sacrum connects to my ilium, where my sacrum hooks to my hips, my sacroiliac joint, my SI joint. I think that's the one that Miss Savarino cracks sometimes. We were talking about the other day, Miss Savarino, we still can't figure out what's going on there. We think you're a freak of nature, I'm sorry. We do. But an amazing freak of nature. Okay? Yeah, high compliment. I don't mean that in a weird way. Yeah, it's just amazing because it doesn't have very much movement. So the fact that you're getting a little pop out of it, it's kind of cool.
Yeah, I used to freak out the doctors all the time in the military. I'd be able to just like do this and be like, and they're like, what the? Yeah.
It's a cartilaginous joint, and so we don't expect it to really. It just should flex, but you're somehow getting a little pop in there.
It feels so good. It's like, it's amazing. I love it. I'm very grateful for that.
Thank you. Thank you. Yes, Mr. Jones.
I was just curious, is this being recorded so we could watch it again?
It is. It is. I'm recording it right now, and I appreciate that. The reason I said it that way is I don't think this is that amazing. I'm just kind of talking about some highlights. You guys have kind of a
I'm just thinking review-wise.
Yeah, cool.
It's easier for me to kind of watch something and follow along with someone than to study on my own, usually.
Sure. I'm down with it. Please. If you can tolerate my voice twice about the same thing, more power to you.
I could do that.
All right. I've said this before, but this is kind of confusing in massage, but they call the ischium, that part of your hip, the sits bone because you sit on it. And you can actually feel it on a hard chair, right? It's the thing that kind of bothers you on a hard chair. You're sitting on it. And so they'll call it the sits bone. This is also confusing because they now call your rotator cuff muscles the sits muscles because they memorize that as an acronym for supraspinatus, infraspinatus, teres minor, because they go together, and subscapularis. And so you'll never hear me say it because I hate it. These are not the sits muscles; these are rotator cuff muscles. But some people call them the sits muscles because they just use that so much. So you got a sits bone and sits muscles, and they have nothing to do with each other. Let's say Pubic symphysis is where the two pubic bones come together in front. It is above your reproductive organs. You should be able to touch it right now. It's that hard bone right there, and that's where the two sides of your hip come together. That is also a cartilaginous joint. And so it moves just a little bit. Miss Carrillo, please.
Is that the one that softens when women get pregnant and then
Yes.
you can accidentally overstretch?
Yeah. That one, by the way, everything softens because relaxin relaxes all the cartilaginous joints in your body. But yes, we hope the pubic symphysis actually stretches open and creates a larger birth canal for the child's head to get through. That's the whole idea. But the sacroiliac joint softens too, so the hips can spread there. Yeah. And all these are reasons why pregnant women get so much low back pain and things like that. There's 100 reasons why. There's a baby pressing on the inside of their back. But that baby is also spreading their hips as it grows and things like that. So there's just a lot going on down there. It's amazing that you guys can make a baby. I mean, make life. It's just... I have a hard time making breakfast. And you guys are like, here, I made a human being. Miss Hendrickson.
Oh yeah, just there's so many changes that go on, and like it's crazy. I mean, especially in the first pregnancy, how much the body has to change, and so quickly too. Like, I mean, that's a really short amount of time to. I mean, when you think about it, to go from like a zygote to a human being. But yeah, I wish I would have had massage at that time.
Yeah. Yeah.
Definitely. Yeah, I think it would have helped a lot.
Yeah. Yeah, and I think we focus just on the physical change, but obviously dealing with your body changing that fast has a huge emotional...
Oh, yeah, and I used to, like, because I was pretty small when I was, like, 18, right before I got pregnant, and then I really had a hard time adjusting to how my body was, just, like, in space. Like, I would just walk around and bump into things all the time because I wasn't used to having this big belly in front of me. So I would be like, oh yeah, I can fit through. Oh no, I can't fit through there anymore.
Yes, your brain still remembers the old you. Yeah.
Yeah, exactly.
Thank you, man. Mr. Richards.
Yeah, they're amazing. I've been watching on YouTube. They do this period pains test on men to see how they react to and most of them can't even move, and they're like, "What, you're doing things while this is going on? You're doing the washing, you're looking after the kids, you're cooking." And most men are just frozen in one place and cannot move an inch. Yeah. So, to the women out there.
Definitely the stronger sex. We'll give it up to them. It's true. It's just a fact. Here's the femur. This is a beautiful picture of it. Notice that the greater trochanter is not the only lumpy thing there. You've got the inner trochanteric crest too. That whole area up there is really lumpy, which is why we're careful about rubbing up, proximally up the leg, because we run into all that stuff. We haven't gone below the knee yet. We're heading there. And so I don't think this test goes much below the knee, too. But you guys should know the acetabular femoral joint, which is your hip joint, the tibial femoral joint, which is your knee joint, and the patella femoral joint. Not a lot of people actually talk about that, which is your kneecap going over your patella. I'm sorry, your kneecap going over your bones there. They'll call that the patella femoral joint. But the two bones coming together are the tibial femoral joint of your knee. We will get into knees later. They're fascinating. They're amazing. But I'm going to go by it right now because I don't think it's on your test. We get to it later. We do, and then we'll be tested on it again later. So let's go past all that. We're not going to do feet right now, and they won't be on your test. At least they shouldn't. And we're not going to do cranial bones right now. We will get to them though. But don't forget about the rib cage. Remember the wonderful rib cage? You got 12 ribs. That's what makes your thoracic area. The thoracic area always has a rib associated with it. The thoracic vertebrae always have a rib associated with it. So if there's 12 thoracic ribs, there's 12 thoracic vertebrae, right? T1 through T12. Remember the first 7 are called what kind of ribs? Thank you, Miss Abelos. Sorry, Mr. Richards. She mouthed out true so well that I just took it truth. Yeah. The next 3 are called what? Mr. Richards, what are those next 3?
I've lost it. So you got the true ribs,
Yeah.
we got the false ribs, and
Yeah.
then the floating.
Yeah, you got it. True,
Okay,
false,
great.
and floating. Yeah. Good. False was correct. Yeah, and the last two are floating because they don't connect into the sacrum at all. The sacrum, I'm sorry, the sternum. Remember, the sternum actually has three parts, really. It's got the body of the sternum. It's got this thing called the manubrium above it. That's this portion up here that actually has this little notch up in the top of it that you can actually feel. And it's got the xiphoid process down here that you can poke on. Yeah. We don't have to get into all that yet. Then we've got the vertebra, the 24 beautiful vertebra, although some of you probably have 25. Did you know that some of you, I don't know who, but somebody in this class probably has 6 lumbar vertebrae instead of 5. Some people are born with an extra 6th lumbar vertebra, and it's very thin and very tiny. Miss Hendrickson, is that you?
No, but I just recently found out I have a little limbus bone on one of my vertebrae, and it's just this little tiny, straight little, bone, attached to the, 3rd or 4th lumbar vertebrae on the, inside part.
Yeah.
It's just kind of cool, because I only found out about it because I happen to have x-rays. So
Yeah.
I was like, I'm one of those cool people who has, an extra bone.
Yeah. And you will, by the way, I don't know if you'll run across seeing, it's very hard to feel the extra vertebrae in people, so you may never notice that. But you will, guys, have clients that have an extra toe and things like that. People are not, look around this room right now. None of you look like anybody else. So it's not surprising that your skeletons would be slightly different. The textbook is telling us about averages. It really is. Anyway, we got the vertebral column, we got the cervical region, right? How many vertebrae are in the cervical region? Hold up your fingers. Thank you. 7. Good. How many thoracic vertebrae? Thank you. 12. How many lumbar vertebrae? 5. What's 5 plus 7? 12. Yeah, just going to help us remember. You got a sacrum. We don't talk about the coccyx very often, but you have a tailbone. And some of you, when you do that kind of forearm move, you kind of are able to kind of pull the meat away from the coccyx without, being weird, which is really cool. Let's see. This is a really good picture of the ligamentum nuchae. The ligamentum nuchae, we know, is a ligament that goes from the external occipital protuberance of the back of your head to the C7, to the spinous process of C7. But this shows you how really it's woven into the neck all the way down. It's a massive ligament. It's very thin, but it goes in all the way. And that is the ligamentum nuchae, or the nuchal ligament they put here. But ligamentum nuchae is how it's usually referred to. And you see that there's a ligament that goes all the way down your spine, by the way. You have more ligaments than muscles. You have more ligaments than muscles. So, we don't study all of them. Just kind of assume that anywhere you're touching, there's probably a ligament there. Ligamentum nuchae helps you hold up your head. Necks are actually much stronger than we think. You can push on them quite hard from the back. Just don't move them quickly. But besides that, go to town on them. Vertebra. Look at the vertebral canal here. That hole in the center. Why is there a hole in the center of your vertebra? I love this. I can almost read your lips now. Man, be very careful what you say. Miss Everson, though, tell me. Yeah, your spinal column actually goes down. This is why when people are like, well, don't hurt my spine. Well, I'd have to break through your bone to get to your spine. And if I break through your bone, we've got other problems. It is very unlikely that you as a massage therapist are going to get to somebody's spine. So unlikely, I've never heard of it once in my entire life from anybody. Again, spines are it's more important to be careful how you stretch them and do anything quickly. This vertebral body is what the weight of your body is born on, right? Each one stacks on top of the other, and they all link together. Okay. There's a vertebral disc. when you go to the chiropractor and they're like, you've slipped a disc, it makes you feel like this disc has slid out. They don't slide out, they're glued to each other. What they really mean is you have a bulging disc. It's pushing out. There's been so much weight on it that it's ruptured a little bit. It has a jelly-like finish. It really is like a jelly-like donut, and a little bit of the jelly is squeezed out because so much weight has gone to it or whatever. But you don't actually ever lose a disc. They don't slip out. They're glued to both bodies of the spine. Okay. What is C1 also called? The atlas. It holds the world on top of it. C2 is called the axis. And this thing, the odontoid process, is literally sticking up so it can interface with this on C1 and allow me to do this. No. C1 in my head allow me to do this. My head is actually rocking on C1 right now. This is C1 rotating around this odontoid process of C2, allowing me to do this. Yes and no are all about your skull, C1 and C2. Yeah. Very cool. Okay. Sacrum, you've got all these little foramen in your sacrum too. The nerves come out. They're not just there by accident. Does the sacrum look like it's got separate vertebrae? It should, because when you were a little baby, it did. They fused together. When you were a baby, you had many more bones than you do now. Many of your bones fused together. Wow, that was not what I wanted to have happen. Many of your bones fused together. No, bear with me, guys. Let's see if I can go back. I hit end, and that was not good. I hope you're getting all this. Okay. Okay, there we go. Sorry, guys. Yes, Miss Hendrickson.
I was just wondering about the, you know how kids have, well, they have more bones, but they also have, like, they don't have a curve in the lower back, where adults do, right? So there's, like, another curve that happens at some point. Is that, like, around puberty that, like, that curve goes into the spine, or is that to do with, like, bones fusing, or is it just the shape of the body or anything like that?
I have absolutely no idea. I didn't realize.
Okay.
I didn't realize kids didn't, and I've had kids. I mean, I didn't birth them, but I raised them, and I don't remember thinking they didn't have. I'm not arguing with you. I'm sure you're right, but I didn't know about this. I've never heard about this. This is foreign to me. So on Monday, get back to me on this.
Okay.
Okay, so C1. C1 is the only vertebra that doesn't have a spinous process, right? Because if it did, I would hit it when my head went back and I'd never be able to look up at the stars. Hold on. Let's move on. Come on, there we go. Okay. By the way, they're giving you all sorts of fancy names for stuff between your vertebrae, but basically, we just call the joints between each vertebrae the intervertebral joints, the joints between the vertebrae. Most people do not get into all the other stuff. All right. Origins and insertions and muscles. Muscles can only do one thing. What is the one thing muscles can do? Please, Miss Everson, please.
Contract.
Yes. And that gives you their action. When they contract, they have to pull those two bones together somehow. That's actually the entire concept, by the way, of kinesiology, right? Is that muscles contract and they pull those two bones together, and if you know what kind of joint they're pulling, you can figure out the action. What is a prime mover? Yes, Miss Rader.
It's the agonist.
It is the agonist, and thank you, because that was going to be my second question. It's going to be like, what's an agonist? It's a prime mover. She's 100% right. It is the muscle doing the action. It's the one doing the hard work. What's an antagonist? Yes, Miss Carrillo.
The one that's doing, it's like arguing with the other muscle. The one that's
It
doing
is the one that
opposite.
can argue with the other muscle. That is one way to put it, absolutely. It's the one that could stop the action. It is the muscle that is lengthening while the agonist or the prime mover is contracting and shortening, right? All those are correct. Everything you said and everything I said is correct. What are synergists? Yes, Miss Correa.
Those are the ones that work together.
Yes. So they're really just things either helping the prime mover or other prime movers. I mean, tomato, tomato. But yes, they are working together in synergy. Yes. What are stabilizers? Yes, Miss Hendrickson.
Isn't that the muscles that just like assist with the action that you're trying to do?
That'd be a synergist.
Or you stable like when you're not moving, like postural muscle?
Yeah. Well, no, they might even stabilize you when you are moving.
Oh, okay.
So, like this example I always use where I'm moving my arm over, it's my pec major and my coracobrachialis and stuff that are moving me over. But if I didn't have stabilizers, my arm would actually be kind of doing this, right? Stabilizers help to stop unwanted movement. When you guys work at a keyboard taking one of my tests, right? Think about this weekend. Miss Dimitruk, as you're working on your 193 question test that you're going to do twice, and you're cursing my name, but loving me at the same time, in order for her to do this, her scapula actually has to lock down to her back. It sounds weird, but you'd never have a crane operating with the base of the crane moving around. You lock the base down, and then the crane works. Well, your scapula is very much like that. So what happens is, and this is why people's shoulders get so tight working at a computer, computer is not hard work. Come on, we sit there in a recliner and we're like, why are my shoulders killing me? Because my rhomboids and serratus anterior and pec minor and trapezius lock my scapula to my back so that my fingers don't wiggle except where I want them to wiggle. In order to do finite stuff with my hands right now, my scapulas have to lock down. Those are stabilizer muscles when they are stabilizing. Rhomboids can be prime movers, but in this case, they're stabilizer muscles. Cool. We've already talked about the way muscles are named. Yes, Miss Clayton, please.
So,
Yes.
When they're locked down and the rhomboids are stabilizing them, does that mean if you want to reduce the pain, you stretch the rhomboids?
Yeah, and just get up and move your shoulders around. Like, take breaks, but absolutely, stretch your rhomboids would be a really good idea. Just get them unlocked for a while. Yeah.
Okay.
We find, by the way, that many, especially the issues massage therapists deal with, are really kind of overuse issues where somebody's been doing the same thing for a long period of time, and we find that the human body does not like to do the same thing for a long period of time. Human bodies are amazing. You can produce a lot of work. They don't like producing the same work over and over again. You guys have found this out while you're doing massage. You want to change your stance, get up on the table, get off the table, put a leg up, put a leg down, use your elbow, use your fist. That's actually the key. Everybody tries to make it about like, no, have the perfect horse stance. No, switch stuff up. Bodies like to switch stuff up. They really do. I want you to think about something when you're looking at this beautiful picture of the human body with its perfect anatomy that shows basically no fascia and its big fat lie. Anyway, that's not what I want you to think about. Look at the overlap. Things that we think about as working one area always overlap to another. So if you look at the back of this person's body, the hamstrings overlap across the knee. The gastrocnemius crosses over the knee too, even though it's not supposed to do that. There's overlap. Your body tends to overlap. Your triceps that are meant to move your elbows actually go across your shoulder a little bit. Your biceps that are meant to move your elbow go across your shoulder a little bit. Your body's got all sorts of built-in overlap because it ties you together better. I mention that because you might want to put that into your massage. Am I actually taking muscles all the way to the end? Am I going a little bit over? That's why we always say make your moves as long as possible. And by the way, I've seen some of you do some incredibly long, incredibly beautiful moves. So I just saw it the other day. I was really amazed. Okay. I've asked you this stuff before, like what are the muscles of scapular movement? Those are the muscles that, it's not the rotator cuff muscles. Those do attach to the scapula, but they don't move the scapula, they move the humerus, right? These are muscles that tie the scapula onto the body. You've got the trapezius, levator scapula, rhomboids, serratus anterior, pectoralis minor. Which ones of those muscles tend to work together if you had to group them? There are a couple of right answers to this, but which ones of these muscles tend to work together, and which ones, because it kind of helps you think. Yeah, Miss Everson, please.
At least the trapezius and the rhomboids.
Yeah, I would say that's good, especially middle trapezius, right? But even upper trapezius and the rhomboids do similar things. I could see that grouping together. Miss Clayton.
The trapezius and levator scapula.
Upper trapezius and levator scapula, yeah. Upper trapezius elevates the shoulders, so does levator scapula. Beautiful. These are the type of answer I'm looking for. What else, people? Miss Rader, please tell me the one I'm thinking of.
Serratus anterior and pec minor.
Yes. By the way, all the other answers were equally good, but that one to me, the serratus anterior and the pec minor both protract, abduct the scapula, and depress it. Both of them, they tend to work together. Yes. All the other answers were equally good too. I think that's all of them that I kind of see as kind of combinations, right? Which means that I'm oversimplifying. I am oversimplifying. But serratus anterior and pec minor work together and can fight with rhomboids, levator scapula, and trapezius. Right? I mean, those are just things to think about, right? Good. And so if you had somebody with really tight shoulders, you'd probably want to loosen up all those. And if I want to lock my shoulders down, right? There's nothing wrong with locking your shoulders down. Your body is designed to do this. But if somebody's typing at the keyboard, it's quite possible that all 5 of those muscles are engaged. Because just locking my rhomboids doesn't actually lock me down. That just makes me walk around like this. My body is smart. My brain is smart. It actually pulls, the serratus pulls forward as the rhomboids pull back to lock it in place, right? You pull both ways. If I just have one muscle pulling, that's called action. So when we lock a place down, it's like when we're flexing our muscle. This is actually not just me flexing my bicep. If I was just flexing my bicep, my arm would be all the way down here. What am I stopping it with? My tricep. To stabilize something, to keep it from moving, we flex both sides, the agonist and antagonist. Yeah? So, to lock down your scapula, you use all 5 of those muscles locked down. Have you ever guys gotten that sore little levator scapula in your neck before? It's murder. That's the tiny little muscle's been locked down for too long. Cool. Beautiful pictures of this that I could talk about this for weeks, but this is what we're not going to. You're going to have to take a test on it. We've talked about trapezius. You guys know that the 3 sections do different things, and I can tell that at least some of you understand, hopefully most of you, understand like that the upper fibers lift up, the lower fibers lift down, the middle fibers actually help to adduct the scapula. Yes, Ms. Clayton, please.
So with the insertions and the origins, is it more common for the muscles to hurt where it inserts, or more common for them to ache where the origin is, or does it just really depend?
No, I have never thought of that question. I'm kind of getting used to that with this class. I do know that origins, in my opinion, origins and insertions, or if I had to pick between that and the muscle bellies, I would pick origin insertions. But I've never thought about which one. I have no idea.
Okay.
Yeah, I'm sorry to say, Mr. Overman, do you have a thought about that?
Yeah, so I don't know if this goes for all muscles or all people, but the one example I have, only because I feel it now, is anytime I work my abs really well, like my ribs up where like the xiphoid process is, right in that area, hurt like I constantly am massaging them because it hurts so bad. Like yesterday, Mr. Craven thought I was rubbing my nipples. So I guess you have to be there. But anyway, Yeah, so in that case, I would say origin, but again, I don't know if that goes for everything or everybody.
Oh, so many good jokes there. Thank you. Thank you. Yeah, I don't know. And Miss Clayton, I was actually running through my head after you said it, and I can think of examples of both.
Okay.
So I kind of feel like when I work my biceps, it's closer to the insertion that I get some stuff going. But when I work my calves, it's closer to the origin. I don't know. I don't know. Miss Young, please.
I think it also might depend on like what you're using the muscles for and like why they're in pain.
Right. Good point. And it also could depend on where you're weakest in that muscle and all sorts of stuff. Yeah. There may not, Miss Clayton, there might be, but there may not be an answer to that. It may just depend person to person, activity to activity, and all that kind of stuff. And like Miss Young said, why they're sore. Yeah.
Okay. I just didn't know if maybe one site was weaker than the other, like the origin is stronger normally than the insertion.
I would assume the origin is stronger than the insertion because the origin is kind of the anchor and it's going down to a smaller point.
Right.
But I don't know what that does. Does that make sense? Like, I don't know that. You're right. I would assume then the insertion would get sore.
Right.
But I don't know that that's true. Yeah.
Okay. All right. Thanks.
Thank you. It's a great question. I love that this is a thinking class. Miss Carrillo.
I was also thinking origin would be the stronger, and it usually covers more broad, but then I thought of the serratus anterior, and I'm pretty sure they're on the ribs, whereas the scapula, to me, it looks like it's just more of a broad grab, and the scapula kind of like floats there in the back. So I guess it just depends each muscle.
That's what I'm getting right now, at least. Yeah. Okay. Remember, we probably forgot about this, but the insertions of the trapezius are the origins of what? Thank you, Miss Ellis. She goes, deltoid. Yes. And why that's so important is, I mean, it's nice because it helps you remember origins and insertions. You know, the lateral 1/3 of the clavicle, the acromion process, spine of the scapula is where the trapezius inserts. And then you know the deltoid comes off that. But it's also nice because it makes sense because your shoulder works this way. My deltoid doesn't just lift up like this. What has to engage now? My trapezius to help an upward rotation. So it makes sense these would be all one sweeping motion, right? It's just kind of cool when you start to think about it in more kinesiology terms. No, we're not going to go to sternocleidomastoid, rhomboids. This is a very important picture. If the serratus anterior and the rhomboids were not labeled here, you would think they were the same muscles, right? A lot of advanced movement specialists actually call it the rhomboid serratus, complex, because they really just meet at the medial scapular border. And we say the rhomboid's attached to the back side of the scapula and the serratus attached to the front side of the scapula at the medial border. That's almost a lie. They just attach to the medial border. And their job is to pull the scapula around your rib cage, front and back, up and down. That's their job. And they work together. We just have a bone in the middle, so we give them two different names. It's almost like when you're driving on a road and all of a sudden it becomes a street, and then it becomes an avenue. I mean, it's really touch and go there. And we teach you this stuff separately in the beginning because it's easier, right? Let's learn the rhomboids. But as you become an advanced massage therapist, I would actually prefer that you never think about the rhomboids without thinking about the serratus anterior, and that you recognize that really they're the same muscle in a way with a bone in the middle of it that moves that bone back and forth. That's their job, right? We talk about them fighting, but they're complementary too. Their job is to move your scapula up and down and front and back. That's their job. It really is one band that goes around your body. And that's why also when they get tight, sometimes it's hard to take a deep breath because you've got bands going around your rib cage now that are tight. Great. Yes, Miss Everson.
I've got a friend that has scoliosis, and her scoliosis actually pulled her rib cage.
Oh yeah.
Popped one of her out of place. So would I work both the rhomboids and the serratus anterior, or the one you just mentioned?
Yeah, no. So yeah, serratus anterior rhomboid's what I just mentioned. I mean, you might. That's a tricky one. You're saying it pull one of her ribs out of place?
Yeah, like I was thinking about it, and I was like, is that one of your intercostals working too hard?
Yes,
or
it could be so many things. It could also be happening at the vertebral column, right? Her vertebra could be one of her thoracic vertebrae could be out of place because of the scoliosis that's pushing the rib out of place. You're gonna have to play with that one.
Okay.
Those are, but by the way, those are all good culprits. Yes. To answer your question shortly, yes. Could be so many things. Scoliosis is challenging, actually. Okay. So I'm not going to go over movements of the body, but you will have them in this chapter, and they're super duper important, right? We all know elevation and depression, and we know protraction or adduction, retraction, abduction, right? We know this is important. You'll see this at the end of your test. Medial rotation of the glenohumeral joint, lateral rotation of the glenohumeral joint. By the way, can anybody tell me what I'm doing right now? Ms. Hendrickson.
I think because you're moving. Wait, is that a horizontal adduction? No. Medial rotation?
It is. Everybody, it's a medial rotation because you would put me in anatomical position, which would be my arm down here, and it would be a medial rotation. So what would this be then?
A lateral rotation.
Yeah. And I'm telling you this because this stuff is hard when you see it on a test. He said to pause to give emphasis. It's hard when you see it on a test that Tapscott doesn't help you on and you have no open book or anything. And you're like, what are they doing? And you don't think medial, because my arm's not moving medial, but you have to put it in anatomical position, and believe it or not, the joint is doing the same thing that it does here. The joint is actually doing the same thing down here. It's different stuff that gets it up here, but this movement, this is medial and lateral rotation. Very important to know that difference. Okay. Pecs. Yep. Please know the difference between pec major and pec minor. Pec minor moves what bone? Pec minor moves what bone? Miss Carrillo.
Scapula?
Yes. Yes. Sorry. I had to think for a second. Yes. Miss Rader, which bone does pec major move?
Is it the glenohumeral joint?
Yes. Yes. Glenohumeral joint or the humerus, but she's exactly right. That's the jointed effect. No, you're right. Either way, I'm just adding to it. That's right. Because the pec major attaches to my arm, so it affects my glenohumeral joint. My pec minor does not do that. It attaches to my scapula. They often work together to help with a movement. That's what we're going to see in kinesiology. When Mr. Jones is doing dips, he is working his pec major, but his pec minor has to pull down on the scapula, otherwise we're going to have big problems. But the pec major is pulling the arm down as the scapula is pulled down by the pec minor. They work together. This is when we start to get into kinesiology where actually multiple muscles are working together. But two different things are happening there, and they're very different. And they're very important when you're trying to find those muscles and work on them. So, if Miss Dimitruk was working on Mr. Godot's incredibly tight pec minor, she might bring his arm over here, not have him do it. Bring his arm over here so that his pec is loose, his pec major is loose, so she can get to the pec minor. And she might elevate and depress his scapula to pin and stretch the pec minor. If she starts doing this stuff, she's pin and stretching the pec major. Yes, Miss Rader.
Oh, I just want to clarify, when you were just doing those movements a little bit ago, and you did this, and you said protraction, and then you said AD,
AB.
and then when you went this way, you said AB duct. But that retraction is AD duct, right?
Yes. Right. Yes. Thank you for watching me. I just was wrong. Yeah.
Oh,
yeah.
Okay.
When I retract, I am adding my scapula closer to my midline, and that's AD duct, adduct. You're absolutely right. I just got on a frenzy and blew it. Thank you. Remember that we've now been talking about muscles that move the scapula around, but there are other muscles that move the humerus around in relationship to the scapula, like your four rotator cuff muscles. Remember? Supraspinatus, infraspinatus, teres minor, and subscapularis. Give integrity to the shoulder joint, but also help move it around. Super important. This is a lovely picture of the latissimus dorsi. Please remember it forever. Forever. Have dreams about it. When it's Christmas time and there's sugar plums dancing in your head, have latissimus dorsi dancing in your head. What's beautiful about it is you get to see not just the size of it, but it comes underneath the axillary region and grabs on the front, which is why it can create a medial rotation. If it came around from the outside, it would create a lateral rotation, but it grabs on from underneath my shirt. So it can, by the way, it can pull my arm down. That's its main job, right? Pull my arm down like this and pull my arm down like this. Those have two different names, by the way. What am I doing here? Yes, Mr. Overman.
Pull up.
Yes. What is this action called, sir, that I'm doing at my
Oh,
glenohumeral joint?
I thought we were talking about the workout. Sorry. So you are doing a adduction.
Thank you, an adduction. What am I doing here, sir?
Extension.
Extension. Both are huge latissimus dorsi things, and both are just pulling my arm down to my body. But when it's kind of in front, it's extension and flexion. Yeah. So extension, adduction. But because it reaches under my arm, it can also do a medial rotation. Yeah. Yeah. Who can list all the muscles that do a medial rotation of the glenohumeral joint? I'm not sure I can, but let's try it. Miss Ablos, what's that mean? Is that you raising your hand? You're doing it.
So it's internal rotation, right?
It is internal rotation, medial rotation.
Internal rotation.
Of the glenohumeral joint.
Of the glenohumeral joint. Okay, you have the deltoid.
Which one?
Anterior.
Yes, everybody. The anterior deltoid runs diagonal. So because it runs diagonal, obviously it can help with a flexion, but it can help with a medial rotation. Anterior deltoid. Good.
You have the latissimus dorsi.
Yes.
The teres major.
Thank you. I was going to just, yes.
You have the subscapularis and the pec major, the end, right?
Subscapularis, that was great, by the way. Pec major. I think that's it. I think
it is.
I don't memorize everything, but I think you just got them all. Yeah.
Yeah.
So she got the subscapularis, remember, reaches underneath here. It's one of my four rotator cuff muscles, so it does it. She got latissimus dorsi, and anytime we say latissimus dorsi, she got teres major, which is not a rotator cuff muscle, and it reaches in front too. She got pec major, because it goes across the glenohumeral joint, boom. And she got the anterior deltoid. I think you did it. I was trying to think if there's anything else. That was really impressive. That's a very hard kind of question. Anyway, that's great. Fantastic. Okay. Moving right along. We just kind of talked about some of this stuff. Just remember, by the way, guys, muscles pull, right? They can only contract. So if something's going to lift my arm, I know this is an abduction, but also if you had to do it to me, if Tapscott was being lazy and you were standing here, you'd have to be on top of my arm to pull it up. Muscles don't push. So the supraspinatus will lift up my arm, right? The infraspinatus is more likely to pull it down. The lats are more likely to pull it down, right? The pecs are more likely to pull it in front, right? Anterior deltoid is more likely to cause a flexion. The posterior deltoid is more likely to cause an extension. Just actually stand there and be like, where would I have to stand to get this person to move that way? By pulling them, not by pushing them. And usually the muscles in front pull me in front. The muscles on the sides pull me on the sides. The muscles underneath pull me back in. The muscles behind me pull me back. That works, 99% of the time. Oh, by the way, this is a beautiful reason why you might want to work the posterior axillary region on somebody. Because look at all the muscles you hit. you hit the infraspinatus and teres minor. By the way, can you guys see the difference between the infraspinatus and teres minor here? I can't. There is a difference, by the way. The teres minor is actually attaching to the lateral border down here, but you can't, on a human body, when rubbing them, you can't tell that. They might as well be all one muscle. Anyway, you hit the infraspinatus, teres minor. They cut the rear deltoid, but you would hit it if you were working back here. Rear deltoid. You cut teres major. You get the head of the triceps brachii, and they're not showing you the latissimus dorsi going through there. So if you want to hit 6 muscles at once, posterior axillary region, bam. High priority targets. You get a lot of muscles all at once, a lot of yum yum all at once. Clients going, ooh, ah, yeah, oh my God, yeah. Then you can impress them and be like, that feels so good because I'm hitting the following 6 muscles. It's true, man. Supraspinatus, I love this picture. I'm not going to go through every muscle, but I love this picture because it also shows you some of the problems that can happen. This is one of the culprits. This might even be part of what Mr. Lee's issue is. By the way, I hope it's okay. I can tell by the way I talk to you guys it's okay when we talk about some of the stuff that you brought up. But Mr. Lee has a shoulder injury, and it's often this supraspinatus tendon that has problems, and when it gets irritated, then it rubs underneath the acromion process, and as this arm comes up, the greater tubercle and this irritated tendon and the acromion process all get smashed together. So it creates problems in this tight little area. And remember, a lot's going on in this shoulder joint because they're not even showing you the bicipital tendons going up in here and attaching up into this area. So there's a lot going on in that area. That's very common. Boom, boom. More interactions there with all sorts of beautiful stuff going on. We're not going to get into it. Oh, subscapularis, though. This would be if you're looking at the front of the body, right? It's underneath for us because we're usually working from the back. But this is why the subscapularis can cause a medial rotation, as Ms. Abelos correctly identified in her very tricky question. Deltoids, boom. Pectoralis major. This picture does not show it very well, but the upper fibers actually insert lower than the lower fibers, which insert upper, which is why the lower fibers actually help pull down, and the upper fibers can actually help pull my shoulder up a little bit. Pectoralis major is a huge muscle that can do just a lot of different things, really, depending on what fibers are working. Coracobrachialis, literally named by its origin insertion. It goes from the coracoid process, just like the pec minor, and inserts into the medial side of the middle of my arm. And so because it's there, it can help with a flexion or horizontal adduction. Miss Clayton, please.
Why do we call the arm region brachialis or brachius when it's called the humerus, the bone?
Yeah, I don't know. Brachial is Latin, I believe, for arm. That's where we get that from. I don't know why they call the arm bone the humerus. My lame answer that's true but not detailed enough is that somebody different named all these different parts. So like if you and I, Miss Clayton, sat down and named everything in the body, we would use some system that you and I agreed on, and we'd use that system over and over again. But what really happened is doctor after doctor after doctor said, I have discovered this thing. We shall call it the humerus, right? And a lot of them used Latin, but a lot of them didn't. And so they get, just like when you discover a star and you're an astronomer and you get to name it whatever you want. It's that kind of thing. So it's all over the board. It just doesn't follow the same process. It's the same thing with muscles. We use a lot of Latin, but some muscles are named by their action, some by their size, some by their origin, some by the Taylor's muscle. I mean, the sartorius literally says Taylor. They didn't even use any of that stuff. And I think sartorius is French. So some French guy probably found it and named it that. So it's just all over the place. That's why. Miss Hendrickson.
Oh yeah, I just had a comment that I remembered from the book about the, well, I think it was regarding like the names of the strokes and stuff like that, but it used to be that French was the like international language that they used for everything. Yeah. It changed to English after that, so like effleurage and petrissage and stuff like that.
Yeah, Swedish massage that was invented by a Swede has, the strokes are named by French names because somebody later gave it prominence and named the stuff in French names. You're absolutely right. Yeah. And that was a more dominant language at the time. Yeah.
Mm-hmm. I think that was before.
Usually the world power at the time gets to kind of set the language.
But France was never was France a
definitely
world
an economic power. Yes, I realize what you're thinking of. You're thinking of like Spain, and then definitely first Spain,
England.
then definitely England, and then the United States. And by the way, if history is true, it won't be the United States forever either. Every world power has been like, yeah, we're it. It's us forever. And about a couple hundred years later, not them anymore. So,
yeah.
Just wanted to show you this picture really quick. Brachialis. Remember, the brachialis is underneath the biceps brachii. It's underneath this guy. We always go to the gym and we're like, we're working out our biceps. Yes, you are. But the thing you're really working out is this big, thick muscle underneath called the brachialis. Don't forget there's two muscles in there. And don't forget the biceps brachii actually attaches across the shoulder. So it actually can help with flexions of the shoulder. Yeah, it's not a strong flexor, I gotcha. But still, it helps with flexions, and it can mess with flexions of the shoulder and cause inflammation in that area and things like that. But yes, that is not its dominant activity at all. True, true. Triceps, gotta love the triceps. Remember, we can't see the third head of the triceps because it's underneath the other two heads, but it's there. They've even got the brachioradialis here, which I don't know if that'll be on your test this time yet because we haven't exactly gotten to it. Just seeing if there's any little highlights. We have not talked about the Anconius. We might be done with the stuff we need to talk about here. We'll do forearms in this class, but we're not at them yet, and so they're not on this test as far as I know. And we will do hands. I love hands. You thought I was obsessed with feet? I'm obsessed with hands too. But there will be some questions on hips and thigh muscles in here. This is a great picture of a lot of the muscles you've now learned about. You've learned about the iliopsoas coming up from the inside, the anterior part of your low back, and hooking way down in your thigh here in the lesser trochanter. So as major here, iliacus here, disappearing under here where you can never get to them, which is why we tend to like to stretch them. You can see all the quads here coming together with all this fascia to hook into your knee, your patella, and then go into your tibial tuberosity on your tibia. We can see all these attachment sites that are around your hips and femurs and all this stuff. Very cool. Good stuff. Okay. And the backside that's so complex. We've got the 6 deep lateral hip rotators, right? Remember, the most superior one is the piriformis, and it can pinch on the sciatic nerve. The most inferior one is the quadratus femoris. They're also the 2 most palpatable ones, and then the other 4 little ones that essentially insert into the medial side of the greater trochanter, all 4 of those do really. Those fit in between those 2, sandwiched in there. The gluteus maximus is over the top of them. Yeah. That's another tricky question, is the muscles that can laterally rotate your hip. But the obvious answers to that are the gluteus maximus and the lateral hip rotators, but there's arguably some other ones. Great, great picture of the iliopsoas. And great picture of why it's really hard to massage, because they've removed all the organs from this person's body so that you can see them. And I haven't met a client without organs down here, so gotta stretch it. Another great picture. Another great picture. Another great picture. I know, I'm just showing you a picture book. You can actually see the obturator internus and externus and how they hook on here. Really kind of cool. Okay. By the way, when they show you ligaments like this, the sacrotuberous ligament, which means it goes from the sacrum to the ischial tuberosity, sacrotuberous ligament, that's 100% true. This ligament exists and it's super important. There's about 45 more ligaments back here that they're not showing you that are smaller. This is just a big key one that you can usually feel. So again, I'm just trying to remind you that we study muscles a lot, but there's just ligaments everywhere tying your body together. Otherwise, it wouldn't work. Your bones are super strong, but you would be really wobbly. You've got all these rubber band support bungees everywhere that are really thick and really strong. These are just some of the highlight ones. Oh, did it say this too, by the way? Hey, we talked about this really briefly, but 15% of the population has part or all of their sciatic nerve running through the piriformis. So it's got a little gap in it, and it runs through there, and then the piriformis really can pinch it, right? That makes a lot of sense. And 15% of the population, that could be the 15% that's getting sciatica all the time. Nice picture here, where you start to see the hamstrings come up here and all the stuff that has to start attaching in here, and how complex these areas are. I really do appreciate just kind of all the different pictures in a different book of all these muscles. Gluteus maximus, inserting into the IT band. Gluteus medius minimus, all that stuff. Here's your IT band. Notice it goes across the knee. It is your lateral support to the knee. And here's your tensor fascia lata. All of your hip adductors, massive. The inside of your thigh is actually much bigger than the front of your thigh. We don't think about that until our legs are rubbing together. But it is. And it's supposed to be, by the way. It's supposed to be. They're really, really important to you getting up. My favorite hip adductor is the gracilis because it runs across the knee and inserts into the pes anserinus. Pes anserinus, thank you. And that is also formed with the sartorius and the semitendinosus. Good stuff. Beautiful picture of the adductor magnus. Remember this hole in it? Adductor hiatus just lets veins and arteries go through and nerves and stuff. All right, we're not getting into all those separately. You guys actually had a very good grasp of these. I was very impressed. All the quads again. I think that gets us to roughly where we need to be for you guys to start looking at this test. Here's the hamstrings. This is a nice picture of the biceps femoris. You can actually see the long head that inserts down here and the short head. So the short head only has one action. It flexes the knee. The long head actually extends the hip and flexes the knee like the other hamstrings do. Good. Oh, is that a pes anserinus picture? Oh my goodness. It's beautiful. You see all the fascial attachments there. I know, it's very moving. Ms. Avalos, please talk to me.
Are we going to be going into or need to know of all the different aponeuroses? I've kind of only focused on 3 really major ones.
What are those 3?
The epicranial, right? The thoracolumbar aponeuroses, and then it's like aspirina or aspirina.
I know what you're talking about, but really we just call it the abdominal aponeuroses.
Right.
Yeah.
So there we go.
So she's right, by the way. By the way, the short answer is yes, ma'am. That's it.
That's it?
Yeah, there are sheets of stuff around, but it's hard to say whether they're just layers of fat. Like, these are the big ones. We got a big one in our tummy, a big one in our back, so abdominal aponeuroses, thoracolumbar aponeuroses, and those tie together and help wrap you around. And the epicranial aponeuroses, which is also called the Gallia aponeuroses, or the Gallia aponeurotica. I like calling it the Gallia aponeurotica because it just sounds, I don't know.
It sounds cool.
Sounds kind of cool, kind of sexy. I got a Gallia aponeurotica.
Yeah.
Yeah. Anyway, but this one's really important too, by the way, because a lot of your stuff hangs kind of off your head. But anyway, those are the 3 big ones. I actually can't think of other ones that I would call aponeuroses that are of any major importance. So yeah, just focus on those. Thank you for asking. Yeah. Those are areas where there's enough fascia coming together that they are really an aponeuroses. Okay. All right, everybody. That's it. We're not doing ankle and foot. We are stopping right